Hello, everyone. I'm Tiff Bortwood. I'm the Managing Director of Australian Genomics. Welcome to DNA Dialogue, the webinar series where we share new developments in health genomics and hear from international leaders in the field. As we come together for this presentation, let's take a moment to acknowledge the traditional custodians of the lands we're all joining from today, the lands of the Aboriginal and Torres Strait Islander people. I'm joining you from Naarm, the land of the Boonwurrung people of the Kulin Nation. I extend my respect to elders past and present of this land, and also all the lands that we work and live on. I acknowledge all First Nations people joining this webinar today. Please feel free to ask questions throughout the presentation using the Q&A function at the bottom of the screen. We will do our best to get through as many questions as we can after the talk. And if you're active on social media, please feel free to post and use the hashtag DNA Dialogue, and please tag Australian or at @AusGenomics. So it's my pleasure now to introduce you to Dr Victoria Nembaware, who will be delivering a talk entitled Development of a Genomic Medicine Workforce in Africa, Implementation, Outcomes and Impact Assessment. Vicky trained in chemistry and microbiology and attained her PhD in bioinformatics from the University of Cape Town. In addition to this more didactic training in bioinformatics and monitoring and evaluation, Vicky has research experience in bioinformatics and public health, and also experience in designing, monitoring and evaluating ICT projects with a particular interest in mobile health. This has been applied to numerous advancements in public health management in South Africa, and she's developing a mobile phone app in collaboration with members of the 83 Africa team to train researchers how to engage and educate the general public on heredity and health in Africa. Vicky is passionate about evidence-based training and mentoring of the next generation of African health researchers, and we are very excited to welcome her here today. Vicky, thank you for joining us.
Fantastic. Thank you so much for having me. It's a privilege to be here and to represent the African Genomic Medicine Training Initiative.
Wonderful. So over to you, and I look forward to having a chat after your talk.
Fantastic. Thank you. So just to state that this is not my work. It's work done in collaboration with many stakeholders across Africa and also globally. And I'm based here in beautiful Cape Town. It's summer here and it's really early in the morning, so it's great to be up and start off with the webinar. So I'll just give a bit of background to give context and of how the African Genomic Medicine Initiative started, and I would then go into the implementation and the impact assessment. I'd like to acknowledge the various collaborators. I've put some logos here. These are not at all conclusive. We've got many more stakeholders, but I just wanted to highlight the key ones. So the African Genomic Medicine Training Initiative was actually started under the H3 Africa Consortium. And I wanted to give you a history of the body which was really responsible for incubating most of these projects. So the body is called the African Society of Human Genetics. And the first president of this society was Professor Charles Rotimi, followed by Michelle Ramsey. And at the moment, the current president is Ambrose Wonkam, and I'm the secretary for the society. The society itself is spread across the continent. At the moment, we've got several official country-affiliated societies, but more are joining. So we're going to color up this map quite soon with official ones, although they are representatives from across most of the African countries. We plan on actually having more members join officially as country members. At the moment, the society is also expanding to actually include affiliate member societies. We've got the African Pharmacogenomics Network, we've got the Dental and Craniofacial Genetic Association, and we've also the genetic counselors who are mobilizing to start their own African association. So basically, based on all these stakeholders who are affiliated with the African Society, we have began to appreciate the enormous amount of genetic diversity that exists on the African continent. I've just highlighted a few findings or reported findings, with one actually implying that about 5 million novel variants have been detected in African populations, of which 78% were population specific. And there are several publications, and obviously this diversity is evident in the phenotype and in the disease diversity that exists across the continent. And this diversity is mainly due to a very complex history, migrations that happen across the continent, whether it's due to political or just resource, which have happened historically. And in addition, we've got a very varied range of climates, which also is associated to different infectious diseases, different availability of nutrition, and so on. So this all has contributed to the different phenotypic and really diverse genetic diversity, with a lot of signatures of local adaptation in it. So given this really diverse genetic genetic diversity across the continent, what the African Society realized was the need to really create a consortium which would facilitate the increase of genetic research across the continent, to really tap into the genetic resources across the continent. And that's when the H3 Africa Consortium was born. And the H3 Africa Consortium has got research projects, had collaborative research centers. It also created a biorepository, and obviously this was coordinated through a coordinating center. There were LC projects, ethical, legal, and social implications, and there was also a Pan-African Bioinformatics Network, HRBioNet, which was really implemented to support the H3 Africa Consortium. Just to give you an idea of how big this was, it was funded, it had over $176 million invested by the US government and the Wellcome Trust, has had over 500 members, and also recruited over 100,000 research participants across Africa. And most of these samples, a quarter of them are in the biorepositories, and there's lots of sequence and phenotype data that is now publicly available to any researcher. But obviously, when this was started, we then thought, there is an odyssey in the translation of research into healthcare. And H3 Africa research projects and other genomics projects that were happening on the continent were not immune to this 17-year odyssey, where it takes such a long time for research findings to be translated into healthcare. And of note is that only 14% of these research projects are really translated into healthcare. I took this diagram from a publication released in 2015. And I thought what was missing here was actually the training and education aspect. You get from priorities for research funding, the publication of these research synthesis, guidelines and evidence, but really a key component is training and education, and particularly of healthcare workers who would then be translating this research into practice. And with this background and with this ethos in mind, during a combined meeting of the Africa Consortium and the African Society of Human Genetics, which happened in 2016 Dakar, Senegal, we had a focus group discussion where we actually launched the African Genomic Medicine Training Initiative and also came up with a strategic plan. And because this really required like full-time work or full-time staff. Eshere Barnett, led by Nikki Muda, then funded this initiative so that we could actually allocate time to coordinating the initiative. And of note is that we had we actually made sure we planned the AGMT, the Genomic Medicine Training Initiative, AGMT, which I'll call AGMT from now on. We planned it based on a framework, the Ken 6-step approach, and we also really focused on competencies, and we also used the Bloom's taxonomy. And after this, we came up with specific aims and a curriculum. And this curriculum was really geared at being sensitive to cultural preferences and norms across the continent, focusing on patient care, and also focusing on task shifting, where we were trying to get nurses to now provide basic genetic counseling to families and individuals. And we also wanted to change the status quo of making the normal kind of approach has been that nurses are mainly data collectors in genomic research. And we wanted to change that. So we also included a module teaching nurses how to conduct research. And we also wanted to address stigma and discrimination, which is experienced across Africa against people living with genomic conditions. So as the title suggests, our focus or pilot was aimed at training nurses. And this is what we then did. And the implementation strategy focused on, after a lot of needs assessments, engaging with stakeholders, we realized that online classrooms would not work. Some of our participants did not have stable internet connection as individuals. So, and also training people face-to-face, traveling people over to specific locations would be too costly. So we decided to do what is called a distributed classroom approach, where trainers record videos of their of the lessons, and then these are uploaded onto our website on Google folders. And classrooms, as you can see in the slide, there's a classroom there which is which then downloads all this material before class, and they watch it together with a facilitator. And during the contact session, the trainer then engages with each class so that they can ask questions and interact. So I think one of the key questions we had when we started is, would this AGMT pilot really have impact? And what we did was actually get ethics approvals for this study, so that every evaluation and data collection data that we collected, we could use for a publication, and we did it in an ethically approved manner. We collected data at baseline. We conducted like a situational analysis. We did pre and post assessments of the participants. And we also are doing, which is almost complete, a maintenance survey to check 7 years after the pilot, whether the nurses have actually maintained what they were taught, and whether we had impact in that way. So when we now had all our data, we decided, how are we going to, we now had a dilemma. We had lots of data, which we'd been kind of analyzing on and off. And right now it's mainly the the maintenance data that we are trying to finalize. But really, we try to use the theory of change, where we focused on our targeted impact and outcome, and then try to assess whether all the assumptions we had put at the start led to those intended outcomes. And I think what we realized was that this was not going to really work for us, because in fact we had two completely separate impacts. We had the training and education um, intervention, and we also were looking at genomic medicine practice. Is our training changing that? So given this, we explored using implementation research. Basically, implementation research tries to bridge the gap between research and practice, as you can see from this diagram. And this implementation research really uses a range of frameworks. So we found one framework, which is called the Practical Robust Implementation and Sustainability Model, which was published in 2018. And the original PRISM model aims to evaluate how the healthcare program or intervention interacts with the recipients to influence program adoption, implementation, maintenance, reach, and effectiveness. But for us, because we're really trying to focus on training and practice, we then adapted this to say, could we adapt this model to say it evaluates how genomic medicine or educational intervention interacts with participants and patients to influence genomic medicine training and practice, that is adoption, implementation, maintenance, reach, and effectiveness. And obviously, there was a key thing that we wanted to highlight, that the PRISM model or framework was really not focusing on training, and that's why we decided to adapt it and include the training bit. And just to show a graphical figure of the PRISM model, as you can see on the left is the original framework, which really shows how the patient perspective, the organizational perspective is really key to the intervention being successful, and the recipients, after the intervention is done, how the implementation and sustainability, external environment all interact with the recipients' characteristics and perspectives to influence adoption, implementation, maintenance, and the reach and effectiveness of what we're doing. And on the right, you can see the adapted model, whereby we've got the training and education intervention separated from the genomic medicine practice. But these two are interacting, and the interaction is mainly through the participants and the patients. And obviously, the training intervention itself, we had to look at factors which affect its implementation, its sustainability and infrastructure, and also the external environment. And given this, we then actually are now finalizing our report or impact assessment, and this is to be submitted for publication very soon. So in terms of the training intervention, we did a baseline survey at the beginning when we're doing our needs assessment and situational analysis based on the Kent 6-step model approach. And we realized that 41% of the institutes that we surveyed, which were 33 institutes in 19 countries, only 41% of them had genomics training. And what was really also really worrying was that the training was not distributed across the countries that these institutes were based in. So it would be little pockets in specific countries that were training. And basically, the impact of our training intervention is that the training model successfully pulled trainers from across the continent. And we pulled trainers because as indicated, most institutes didn't have trainers, and because our distributed approach allowed us to actually engage with trainers from across the continent and put a curriculum together that was comprehensive and that was not limited by lack of trainers in specific modules or aspects that we wanted to address. And we also paired trainers to have a senior trainer and a junior trainer as a capacity building effort. We leverage off the H3 Barnet infrastructure. We actually had more reach of participants due to this distributed approach, and facilitators were trained. We also realized that implementation really depends on political stability in some of the countries. We had, for example, political instability in one country whereby internet was shut, access was shut, and the facilitator had to actually drive across a border to download material, bring it back to class, and then interact with the trainer via us at the coordinating center. And we also had a lot of language issues. So in the now that we're revamping our curriculum based on this assessment, we are really looking at translating our material into French and Arabic, because a lot of countries could not participate because we're providing the training in English. I just wanted to also highlight that at baseline, we took a lot of characteristics: gender, age, years of practice, highest education achieved of the nurses, and even we've got more characteristics that we also captured from demographics, but I just thought I should take a snapshot of this because of some logistic regression analysis that we are doing. We also checked what was motivating nurses to actually attend this training, which most had never been exposed to. We realized a lot of them were actually involved in some genetic study, and they were not being trained on what genetics is. They would just be taught how to collect data, and that was it. And some had family members with a genetic condition, and some were really motivated by what they were seeing on the field and realizing their limitations in knowledge and in practice, as they were seeing a lot of patients with genetic conditions. We also looked at competencies and tasks to see what the nurses would like actually to do in the clinics. And as you can see, there was a statistically significant difference at baseline compared to exit, and also in the maintenance stage, of what the nurses actually wanted to do. I just highlighted two here. They were really keen on discussing the need for genetic testing with parents, for providing emotional support to patients and families. So it seems they were really geared towards some sort of task shifting given the lack of genetic counselors on the continent. Another impact of this study is that it has actually stimulated more healthcare workers to be interested. So in 2017 and 2019, we ran 2 iterations specifically for nurses. And then the 3rd and 4th iterations were now for pathologists and doctors. And as you can see, the number of registered participants increased from around 200 to 300 to over 800 in one kind of iteration. And because these are in distributed classrooms, the quality is not affected that much, because we've got trainers or facilitators in each classroom, and also the engagement online. And just to also highlight that the number of countries that are joining the training is also expanding. In light blue are the initial classrooms or countries, and then in darker blue are the extra classrooms that have been added over the years. And this number is likely to increase as well if we provide the material in French and in Arabic. Another really great thing is that 2 nurses have reached out. They would like to do their PhDs in genomic medicine implementation research. We also have 2 nurse colleges that have reached out for help in integrating the curriculum into their undergraduate course or training. And I'll just briefly also touch on the practice, the impact on the practice. We discovered that there was a statistically significant change in knowledge, confidence, and behaviors of the nurses at baseline versus at exit and at maintenance. Some participants published their first peer-reviewed publications as a result of this course. And it's really great because it was really fantastic to see the nurses being transitioning from being data collectors to actually coming up with their own research questions. Obviously, due to limited fundings and limited time, a lot of the studies could not be implemented, but systematic reviews and scoping reviews were published. And we are now looking at maybe adapting that model a little bit to make sure that we provide more mentorship for some classes so that they can implement their studies. For the class, marks were only given for them coming up with a really good proposal and writing that up. And implementation was really bonus. And another other impact include a clinic in Kenya is now really integrating very brief genetic counseling into their or education in their sickle cell disease clinic. And all the nurses there who've been attending the course actually draw pedigrees and explain inheritance to their participants. And we also have participants from Uganda who were providing some counseling. And when they realized that there were some really complex genetic courses, they reached out to genetic counselors at UCT. We just want to highlight that we've tried to publish as much as possible each step of the way. And we also have some resources available, like the competencies, the course itself is available on our website. And we're now looking at developing an implementation toolkit, and we'll be reaching out to your genomic training initiative because of your experience in developing toolkits, and we are now rounding up the evaluation, and we hope to publish this evaluation data very soon. And in terms of timeline, we in 2017 we started with the nest piloting. We also developed an application for high school learners, where high school learners can engage with people who are working in genomics and related fields, just to encourage learners to take up careers or to understand better. We also make genomics fun through this application. And what's really great is this is in partnership with the Ministry of Education here in the Western Cape, in Cape Town. And so the ministry and us have been collaborating in hosting an annual quiz competition where all the high school learners from the district, first it was district and then it has expanded to province. And in 2021, we expanded, as indicated earlier, to doctors, lab pathologists, and nurses. And we are also co-developing other short courses with various stakeholders. And we are hoping that in 2024, we will start with the developing or integrating some of our short courses into undergraduate and postgraduate training. I just want to acknowledge the planning committee, which has got members from across the globe, facilitators, trainers, and the patients. And I also want to acknowledge Amy, who I met recently and has given some feedback on our evaluation concept. And just to finish off, I just want to highlight the variability in Africa. It's not only phenotypic and genomic, it's also at a linguistic level. And this is just to say thank you in the several African languages. I can pronounce most of them except the Ethiopian one, which I will learn soon. And from South Africa, it's Nyabonga, Nkosi, and Danki. Thank you.
Vicky, thank you so much for taking us on that journey. What an extraordinary presentation and a huge amount of work that's been undertaken by you and the team since 2017. I was particularly struck by the reference to the missing workforce element in the that sort of 17-year odyssey to implementation, from translation from basic research into practice, and the fact that that was highlighted so early as an intervention that needed to happen, and support genomic medicine implementation across Africa. So thank you for that presentation. There are a few points you raised I'd like to chat about a little further, and I better open the chat so I don't just monopolize you with my own questions. Oh yes, Amy and Bronwyn have already, I knew that they were online and I knew they'd be very excited by your presentation. So we'll get to them in a minute. So I'm very interested in the evaluation you undertook to consider the success of this program, both from the retention of knowledge in the trainees after 7 years. I know you touched on other demonstrations of outcomes from the program, but is there discussion about establishing more formal evaluations of how genomic medicine is practiced in different countries, and whether metrics within that evaluation can point back to elements that were delivered in this training program? Like, is there a formal structured evaluation of genomic medicine practice in different countries in Africa?
That's an excellent question. So what I can do is point you to one of the first survey that we did. And this survey was really to get the, I think it's one of my last slide. Maybe I can put it up again.
Mm-hmm.
So it was really to assess the genomic medicine activities that were happening in Africa and the implications for policy on this. And I think so this is the paper. I'm not sure if you can see it, a view on genomic medicine activities in Africa, implications for policy. So we just did a survey to assess what was happening across the continent, and also assessed the infrastructure people had, the guidelines, and so on. But what's interesting as well is we also included a lot of self-reflection and resource identification questions in our curricula. So the nurses and the doctors themselves are actually asked, what are you doing, so that we can actually get that data. So all that data is actually on our learning management platform. And honestly, that's why this evaluation has taken long and to just get together, because questions were even asked during the course itself, and we did a survey before. So we've got a lot of data on what's being done on the continent in terms of genomic medicine.
Very interesting. What a rich data set, to inform policy. And, I'm conscious too, from the World Health Organization perspective, how important having those data to inform sort of local policy as well as global policy. I was also very interested in your point about the curriculum being very careful about individual and cultural preferences. The huge number of countries you're covering with very different cultural backgrounds, but your specific point about your awareness of stigma and discrimination of people living with genomic conditions, which is in common across Africa. Could you expand on that? I was a bit surprised by that statement.
Yes, definitely. So I think one of the aspects is that there are different genetic conditions across, the continent. And in the extreme cases, for example, in Tanzania, there is a belief that, getting body parts from a person with albinism can bring prosperity or luck or something like that. So
Yeah.
actually, if you're an albino, you are targeted for people
Yeah.
chopping off body parts, which is actually really horrific.
Mm.
There are also some problems with people with sickle cell disease accessing healthcare, because sometimes people don't understand what's going on, and they think that they are addicted to morphine or to because they get really severe painful crisis.
Mm.
So I think the stigma and discrimination varies across the continent, but we needed to be sensitive to that and to address that, and actually show how inheritance works. Because as much as um, you, the nurses themselves are making up the community, and you cannot separate them from their cultural norms. So
Mm.
it was important to address some of those things in a culturally appropriate manner. And another aspect I can highlight is that when we looked at other genomic medicine training initiatives, like genomic medicine training curricula that were available, none of them had community engagement. And we included a module for community engagement because we realized culturally a nurse cannot just go into a community, if it's a community nurse, and start talking about genomics or inheritance. They need to actually get buy-in from the chief. So our curriculum also included a component um, of um, of community engagement in it, so that the nurses could actually include that when they are doing their community work or community education or health promotion work. I'm not sure if that answers
No,
the
it does.
question.
That's fascinating. Thank you. That's really helpful.
Great.
All right, I might go to some of the questions.
Sure.
So Amy asks, hi Vicky, such an amazing program. My question is about the varied programs you're running. How much overlap is there in curricula? And are you able to track individuals or cohorts moving between the programs? So for example, a stacked curriculum.
Yeah. So we did start off with the nurses in the pilot and then expanded. But what's great is that one of the key lessons, actually, I should go backwards. We learned a lot from Genomic Medicine England, because they had run a similar kind of project. And what they had realized is that if you put nurses, doctors, and everyone in one class, that doesn't work. So we adapted that a little bit and made sure that there was a base curriculum where everyone learned the basics. And then there would be three different, streams. The nurses going on to their own stream and the doctors going on to their own stream. And the fantastic thing about following up is that instead of us following up um, some of the individuals, we actually ask the facilitators, because they're on the ground and they know the nurses in person, so that then it can be followed up like that. So the ethical approvals we got were for the pilot, and that's the one we're rounding up for the nurses. And we are now planning on extending that approval for the other cohorts. But at the moment, we were focusing on really assessing the first pilot that we did. I hope that that
No,
answers the
that's
question,
great.
Amy. Yeah,
And
great.
and in your, I mean, understanding that you're focusing on the evaluation of the nurses, the original pilot initially, in your data collection from the other cohorts, from the clinicians and the pathologists, have you seen, are there any glaring differences in their objectives and their perceived outcomes of the courses yet?
Yeah, so with the doctors and the nurses, the doctors and the pathologists and the pharmacists, we haven't analyzed that data, because yeah, just because of
Because you're
limited
busy.
time.
Yeah, fair
Yeah,
enough.
yeah, but it would be interesting. And I think the surveys as well changed a little bit. So some of the data would be coming from the classroom participation, feedback, because some of the evaluations were embedded in the learning that was being done. I mean, the evaluation data from the learning, we haven't even started, working on that. We've just started working on the survey data. So I think one of the PhD students was interested in now looking at the evaluation questions that were embedded within the training. So maybe give it another year or two.
Yeah, such a rich data set you have. That's amazing. So Bronwyn also asked a question. Thank you for your presentation. It's phenomenal to see the amount of data you've collected over time. I was intrigued by the change in what your health professionals wanted. Can you expand on that a little bit? So the change temporally in what people wanted out of the courses.
Yeah, so I think one of the things is with the nurses, I think they really appreciated the fact that they could now actually do research. And I think a great thing has been, can we have more support so that we publish the research questions that we've got? And some of the changes that they were kind of really gunning for was for their for the course itself to actually be accredited in their own countries so that they get CPD points. In South Africa, it was, and then the other countries were still working on getting accreditation when the course started. So that's other things that the nurses were also really keen on. And some of the changes as well had to do with officially that if it were possible, they would be recognized as genomics or genetic nurses.
Yes.
Because a lot of them were working in the genetics field, but were not taught anything about genetics, but had been observing a lot. So I think one of the things was a real great need to see some accreditation and recognition of the work they contribute to in genetics and genomics. And I guess the language issue was also something they asked for quite a bit. That the Francophone countries and the Arabic countries, some of them had to get a translator in their classrooms by themselves. The facilitator either could speak very good English and very good French and could translate, but we realized that was something that the nurses really needed. And I guess there were also some changes. For example, they requested that the doctors they were working with be trained as well, because we had a lot of negative, unintended consequences of the training. For example, one classroom shut down because the nurses went back to the doctors they were working with, and because of the hierarchy that exists, I guess, in the healthcare sector, they went back and when we now tried to explain to this doctor that a patient they were seeing actually could have a genetic condition, and maybe that patient should be sent for referral. And I guess that didn't go down very well, and that classroom, was actually shut down. So there was also a request for us to make sure that the doctors we're working with were trained, so that they could have discussions with their medical attendees on the same level or give suggestions, I guess. I'm not sure if that answers it. Yeah.
No, it does. No, I'm very much enjoying the conversation. I was interested too. So, because clearly you haven't got enough on your to-do list, but if you had an opportunity to consider other avenues you'd like to take this work, and noting too your interest in mobile apps and sort of digital tools and things like that, like would you consider, like you mentioned, the the clinic in Kenya where nurses are drawing pedigrees, for example, or, you know, in Uganda where there's a process whereby a complex patient that's when the nurses will reach out to UCT and seek genetic counselling advice. Would you consider expanding resources for things like decision aids in that sort of context, or perhaps digital tools to facilitate pedigree development? Or like, where would you like to take this if, you know, time and resources notwithstanding?
Yeah, I mean, that's a fantastic idea. I hadn't thought of it. But one of the things we were doing was discussing with a virtual reality lab to
Oh.
see whether we could include a virtual reality aspect into the course. We did that for the high school learners, and it was well received, and that was something that we're trying to include. And I guess some of the aspects was to create a community of practice. And one of the PhD students who's starting in Feb was actually coordinating the genomic research. She was coordinating a research society or something, and she's really keen to start a community of practice. We have reached out and are interacting with the Global Nurses Alliance, Genetics Alliance. And there are also other avenues we're looking at. For example, making sure that we've got specialist nurses that are recognized, like genetic nurses. So we've started liaising with the Health Professional Council here in South Africa. So we'll see how that goes and whether we can scale that up continentally. We're also planning a workshop in Uganda 2024, just to get all stakeholders together and, try and brainstorm how we can enrich this course and training and make it really aligned to the genomic medicine practice on the continent. But I really appreciate your idea about the decision making. I hadn't thought of that, and it's something that could be easily implemented based on some of the apps that we are developing already. Yeah, thank you.
I think too, I mean, it's amazing that these resources you make publicly available on your website. And, you know, I know Amy and Bronwyn, who ask questions, you know, are often saying that there needs to be accessibility and availability of resources so people aren't duplicating effort. I'd like to ask a question, you know, so, I mean, clearly this has been a very successful and impactful program. In terms of sustainability of your program, Vicky, what's the future look like?
That's a very good question. So I think the future at the moment is something that we are looking into. For example, with the classrooms that have been reaching out, two have officially, stated that they really do need to get their curriculum, revamped at their nurses college. An interesting thing I just want to point out was that the classroom from Egypt in 2017 actually were all the nursing professors from that university. They attended the course and they were very keen. So they've reached out, and we also have several classes here in a university here in South Africa who's reached out. So I think one of the key things is for us to turn this training from a skills development project to an education kind of project where we can develop toolkits for how the universities can actually, integrate genetics and genomics into their curriculum. And then another aspect is that we've been liaising with our affiliate societies, like the pharmacogenomics one,
Yes.
the cranial and dental one. They would like courses to be developed for their specific, societies in a similar model. So in terms of sustainability, I guess it's skills development, and you try and push that to be sustained in universities, and make sure that there is recognition for the nurses who get training, and also then move to short courses for other genomic medicine areas that are
Practices, yeah.
key. Yes.
Excellent. And hopefully capture some of the children that you've enthused in high school through the app as they move into uni. Now, I can no longer hear you, Vicky.
Okay, can you hear me now?
Yes, perfect. Thank you.
Fantastic. Yes, hopefully move the students there, and also hopefully move a lot of research with nurses into research and practice. I think it's like a whole feedback loop, you know. The nurses are now trying to contribute to the practice and to research. Yeah, so and obviously we would like to do away with depending on funding, like which is short term, because right now we are almost running out of funding. I mean, Nikki
Right.
Moda is really funding the initiative through Esri Barnett, and Esri Africa has come to an end. It's just on a no-cost extension. So we are trying to write for more grants to keep this going. Until at least most of the curricula has been absorbed into the universities,
Yes.
then I think that would be really a huge impact in terms of sustainability.
Yes, absolutely. So you've still got a lot of things to do, or you're going to stay busy over the coming period. And look, we'd love to continue the conversation, but also particularly learn more of the outcomes of this body of work as your evaluations mature over the next sort of year, 18 months. So thank you so much for joining us today. It's been just fascinating.
No, thank you for having me. It's been fantastic. Thank you so much.
Excellent.
Great.
Thanks, Vicky. And thank you all for joining us today for this really amazing presentation. We're actually as we move into planning for DNA Dialogue seminars in 2024, we would appreciate you completing, we're just sending around a really brief, like 2-minute survey for your feedback, and that will be hitting your inboxes in the coming days. Our next DNA Dialogue will be returning on the 29th of February next year, and featuring Mashal Sahel from the Centre of Genome Sciences and the National Autonomous University of Mexico. I'd also like to take a brief moment to really thank the comms team for all their work they've done in pulling together this fascinating series. They do all the hard work, and I get to chat to all these wonderful people. I think it's great. It's a great deal. So Dorothy, Liana, Ellie, and Will, particularly for your efforts in bringing us this series of seminars. Thank you so much. And lastly, just wishing you all a very happy and relaxing holiday period with your loved ones. And we'll see you again in 2024. Thank you all. Bye.